Thank you, Chairperson, for the very warm introduction. A pleasure to be here. And I'm going to talk about how diabetes specific nutrition is important. And this is distinct from the taking protein and then doing exercise and trying to body build. So, diabetes specific nutrition is a completely different thing. And my focus will be to show how it is different from routine nutrition. So this is my disclaimer, and this is my the agenda. I'll talk about the challenges. Second, I'll talk about the guidelines and evidence for medical nutrition therapy. Third, I'll talk about diabetes specific nutrition. Many of the studies have been done with Ensure Diabetes Care, which I'll be presenting, and of course, advanced diabetes specific nutrition, because that looks at macros in a prominent way rather than just looking at protein. So let's begin with a case. Now, this is a 75-year-old lady who came to us with a history of bilateral knee osteoarthritis. She doesn't want knee replacement, and she's got diabetes management issues, and she also wants to manage her obesity. So this is a visit in April, and as you can see, she's a homemaker, and her weight on presentation was about 87 kilos. Diabetes since 12 years. The body mass index was about 32. HbA1c was 7.7. She used to drink socially, not an alcoholic, but she doesn't smoke, and she's on thyroxine, about 50 microgram per day. She's also on empagliflozin and linagliptin. So she was initiated on tirzepatide 2.5 mg once a week and for a month, and then the dose was increased to 5 mg once a week. So this is her body composition analysis when we started the tirzepatide, and what you will see that she has got a higher the weight. She also has a slightly relatively lower skeletal muscle mass, and then she has a body fat mass is higher. You can see that the muscular system is pretty all right for her age, given that you can see the muscle nutrition index, or what is also called the skeletal muscle mass index, a value you can see within the normal for her age, in fact in the upper side. But the worry is she's 75 years old, and if you start her on tirzepatide, she's going to lose muscle mass, and whether we are going to manage her in the right way or not. So just to give a prelude to that situation, and our treatment goals for a patient like this are: number one, we want to control the glucose, and we don't want whatever muscle nutrition that we give to worsen the hyperglycemia. Second, we want to reduce the risk of nutritional deficiencies. Third, we want weight loss. Fourth, we want to preserve the skeletal muscle mass. Now, the two important things for preventing the muscle loss are strength training and protein intake. Among them, the more important is strength training. There's no point in taking protein without doing strength training. So strength training is very important for this patient. And here the question is, why diabetes remains difficult? Now, our Indian diet is rich in low quality carbohydrates like white rice, refined flour, added sugar, high in saturated fats, and we all know that we are not eating enough protein. Well, we don't have to take too much protein. We just have to take enough protein. I think the obsession with protein is not good, but at the same time, not taking protein is also not an option. So the important thing is to eat our diet. Now, this is a rough classification, but if you see across the country, some parts of India have fat heavy diets, some have carb heavy diets, and overall, if you see, the carb intake is high. Now, if you see the ICMR INDIAB study, they say that if you replace just 5% of carbs with 5% of high quality proteins, you get a 10% lower risk of diabetes. So we don't have to say take 50 grams protein, 100 grams protein, 200 grams protein, take whey isolate, concentrate. No, we just have to take enough protein. a good all-round protein, keeping the other macros in mind and the micro nutrients in mind. We look at our Indian patients now, because of the genetics, because of the lifestyle, and because of our diet being high in low quality carbohydrates, and of course vitamin D deficiency, B12 deficiency, micronutrient deficiency, our diet needs to be better. And how can we look at diabetes specific nutrition? Now, the goal of diabetes specific nutrition is personalized. Many people take a meal and then they take a protein shake. No, that's not the right thing. That's a fake shake. What they have to do is to use the supplement, the diabetes nutrition supplement, whatever protein shake they are using, make sure they're taking a diabetes specific one. And number two, use it as a meal replacement or as a snack replacement, not on top of the food that they already take, not like a dessert. So the four important pillars are to restrict the overall calories. Second is to improve your nutrition quality. Third is to help in weight loss. Fourth is to improve glucose levels. And finally, to improve the HbA1c as well as fasting glucose. Now, most guidelines, without exception, every guideline talks about medical nutrition therapy with diabetes specific nutrition in the context of meal replacements, in the context of formulations which release carbohydrates very slowly. And very important, isomaltulose, which stabilizes the glucose levels and reduces variability because of its absorption being very gradual. And I think about 5 to 7% of weight loss is good enough in many patients for diabetes management. But there are barriers to medical nutrition therapy in India. Of course, incorporating it as part of the daily meal plan is difficult. Many of the formulas are not good. They don't contain good quality carbohydrates, but the formulas which contain slowly digestible carbohydrate and fiber will increase satiety and will help the additional supporting weight loss to the therapy that you give. And if you look at use of diabetes specific nutrition formulas to replace breakfast and as an afternoon snack, both can improve glucose control. And it's very easy to prepare, it's convenient. You put 5 scoops in a cup of water and take it. If you want, you can put it in a glass of water. So that's been the story, and with better and better formula, you can see better results. So if you see the advanced diabetes specific nutrition formula of the advanced ensure diabetes care, it is slowly digestible carbohydrates. It's got myo-inositol, it's got isomaltose, it's got a mixture of soluble and insoluble fiber. And what about protein? It does have a dual blend of casein and soy protein, and it's got all the micronutrients. So it gives the slowly digestible carbohydrate means that the glucose doesn't spike. That means the blood glucose rises slowly and remains slowly. And we all know that myo-inositol can improve insulin sensitivity, because inositols are important insulin second messengers that enhance glucose utilization by the cell. Insulin acts via the glucose utilization, and inositol supplementation could help it. If you look at healthy adults and if you compare with adults with insulin resistance, and then if you look at the addition of myo-inositol, you can see the myo-inositol will help in GLUT4 translocation. And when the GLUT4 goes to the surface of the cell brings glucose through those chambers. So that's how they work. And it has important role to preserve the muscle mass. And if you see the clinical evidence, it reduces fasting and HbA1c. It also improves the HOMA beta, and the diabetes specific nutrition, as you can see on your left, it has a twofold reduction in it shows a twofold reduction in the fat mass and a twofold increase in the fat free, that is muscle mass. And it can also reduce waist circumference, and that means it is helping in some sort of a fat selective weight loss. There's data that it will reduce the visceral fat or the visceral adipose tissue, and that's also important. And let's come back to my patient. Now, coming back to my patient, this patient, as you know, the weight was in April, The weight was about 87. It came down to 82. So she lost 5 kilos. Uh, she was having a BMI of 31, 32. It came down to about 30. The knee pain got better. The HbA1c came from 7.7 to 6.4. Of course, linagliptin was replaced with tirzepatide. Empagliflozin was continued, and tirzepatide 5 mg continued, because you don't require, in a 75-year-old lady, you don't require her weight loss to come by 20% or 30%. No, I think you've got a good weight loss and she's happy with that weight loss. Sugars are controlled. She feels much better, and that's the proof of the pudding. This is the in-body analysis after 5 months of tirzepatide. Remember, she was on a diabetes-specific nutrition, ensure diabetes care, plus she was taking diet control. But most importantly, she was also doing strength training. And here, I will compare the two. Let me go back. You can see that despite the use of tirzepatide and despite the weight loss, you can see the muscle mass has declined a little bit but remained normal. You can see it's stabilizing. You can see in the second one, the muscle mass coming down with time and then stabilizing. You'll also see the fat percentage, body fat coming down, and you'll see the weight coming down here. So in the in-body body composition report, you can see these trends. And today, by just giving a GLP-1 or even medical, diet control, when you add protein, when you add strength training, you can see these changes straight away. Now this is a comparison. You can see the visceral fat coming down. You can see the total weight improving. You can see the muscle mass stabilizing, so on and so forth. So friends, I'd like to conclude by saying that an increase in the prevalence of obesity related diseases, especially insulin resistant type 2 diabetes, is, we are seeing it in India. And today people are talking about GLP-1s as one of the major treatments. But even before, weight loss was considered important. Whether it is diet, exercise, SGLT2, GLP-1, there will be weight loss, and to prevent muscle loss, we have to give good quality protein. Now, instead of giving a heavy protein, it's better to look at the macros where you have good quality carbs, good quality fiber, good quality protein, and good quality fat, and add it to the regimen so that that becomes an overall meal replacement than a top up. Of course, when we look at, say, whey isolate for, say, lactose intolerant patients, or whey hydrolysate, those are for, whey hydrolysate are very good for athletes and people who are doing bodybuilding and all that. We don't have to insist on it for our patients with diabetes. And guidelines also recommend a very evidence-based, transcultural, patient-centric nutrition approaches with lifestyle intervention and the use of good quality nutrition formulas very carefully, very judiciously, as a snack replacement or as a meal replacement will work wonders. And that won't work wonders if you're just giving protein, but if you give an overall balanced formula, that will give the benefit. So advanced diabetes specific nutrition formulas with micronutrients will improve your glucose homeostasis, support the weight loss, prevent the protein, the muscle mass from going down if coupled with strength training, and will have effects on other metabolic outcomes as well. Friends, it's been a pleasure discussing this topic with you, and thank you very much for listening.